Hello, everybody. Welcome to Be Well Live. My name is Dr. Melanie Carminati, and we are continuing Be Well Live, despite the fact that our series ended because we had many people who really enjoyed the information that we were giving out in our talks and the guests that I was bringing on. So today I'm very happy to have Dr. Rakhil Rubinova here. We're going to be speaking about osteoporosis. So for those who don't know Dr. Rubinova, she is an adult endocrinologist with special interest and expertise in diabetes education, osteoporosis, and bone metabolic diseases. She runs her own practice out of Rego Park in New York. She started her education with a degree in family nutrition sciences out of CUNY Queens College, and then received her medical degree at NYIT's New York College of Osteopathic Medicine. Dr. Rubinova completed her residency in internal medicine at New York Presbyterian Queens with an additional year as chief resident. She completed her research fellowship in endocrinology and metabolism at Strong Memorial Hospital at the University of Rochester Medical Center with the focus on metabolic bone disease and treatment. Dr. Rubinova holds dual board certifications in internal medicine and endocrinology and metabolism. Dr. Rubinova worked in large academic medical centers, has experience in both clinical as well as benchmark research, values advancement in medical education. And she has extensive experience in treatment of diabetes-related complications, obesity, weight management, thyroid, parathyroid, osteoporosis, bone mineral disorders, PCOS, infertility, adrenal disorders, and male health. So it's pretty encompassing. Right. So Dr. Rubinova, thank you so much for being here. I am very much looking forward to our chat because you always bring some great information. So since we're talking about osteoporosis, why don't we start off with describing what is osteoporosis? What would you say?
Yes, hi. Thank you, Melanie. It's a pleasure to be here today. I'm looking forward to this opportunity, and hopefully we can share some insight in this silent disorder. Osteoporosis, in my mind, is a disease of aging, and it's very important to understand that most of our population is going in that direction. We are all aging. And because it's a disorder of aging and it's a disease that is very important to understand. What is osteoporosis? It's a disease of brittle bones, in simple terms. As we age, our bones age, and the strength of the bone changes. This strength of the bone decreases slowly. So how does this happen? When does this happen? Why does this happen is very important to understand. There are usually no symptoms. And the concern, because there are no symptoms, is why do we worry? Okay. The first symptom that most patients with osteoporosis have is a fracture. So the disease leads to fragility fractures, and they're fairly common. The data quotes that 1 in every 3 women and 1 in every 5 men is at risk for these fragility fractures. Where do these fractures happen? These fractures usually happen most commonly in the spine, in the hips, and in the wrists. Because it's a disease of brittle bones, we have to understand, well, how do we find out who has brittle bones? So the definition of osteoporosis has been coined by WHO, which is an organization that used bone density qualifications to describe osteoporosis, so we understand what it is. So bone density, and I'm going to divert a little bit, is a machine that we use in the spine. It's a machine that we use that measures the strength of the bone. And when the strength of the bone is measured by this X-ray machine, which gives minimal radiation, it gives us a value. So most of us know as osteoporosis expressed in T-scores,
Right.
and T-scores less than minus 2.5 is defined as brittle bone or at risk for fragility fractures. Based on this diagnosis that's derived from bone density, we basically treat and understand the disease.
Great. So let's talk about predisposing factors for osteoporosis, because I know there's both non-modifiable and modifiable risk factors. I'll even just list some of the ones that I know, and then please chime in. So some non-modifiable risk factors are age. I know that if you're older than 50, if you're of Caucasian Asian descent, Northern European descent, if you've gone through menopause, if there's a family history, long periods of inactivity, immobilization, femoral neck bone mineral density, those are all non-modifiable, right? So to start off, can't change most of those things. But then modifiable, physical inactivity, tobacco, alcohol, medications, depression, diet and nutrition. What else would you say, Dr. Rubinova?
So these are actually great things and risks that we could address. And I actually do like to look at the risk factors as things that we can change and things that we cannot change.
Right.
So in addition to all of this, I would probably add some of the weight issues. So it's very important that you have appropriate muscle weight and weight on your bones, because these are protective mechanisms. So if I just add to the, it's very difficult to sort of look at these separately, but I'll give you sort of a little bit of a background. With these modifiable risk factors, it's important to understand that we build our bones from day one when we're born. So these modifiable risk factors, and the most important part of it is a diet and nutrition and sufficient sort of nutrient intake that starts from day one. And in the beginning, when we're young, we're able actually to keep up with nutrition, and that protects our bones. After a certain period of time, nutrition may not be just sufficient. So that means we have to understand at which point in our life these risk factors that are modifiable need to be addressed. I know there's a lot of information and data on vitamin D deficiency and insufficiency. People who have eating disorders or struggle with eating disorders, as I may, they will be at a higher risk, and at earlier age will basically have bone issues. Exercise is important in the sense that you build muscle, and muscle is a protective mechanism for your bones. And there are, of course, different types of exercises, which I rely heavily on my sort of counterparts to work with the patients, because there's a difference in high impact versus low impact exercises. There are certain exercises that will protect, and there are others that, if are not done appropriately, can actually harm and lead to fractures. In the fixed risk factors, which is something that sort of needs to be understood, is that as we age, these risk factors, and I can add to the list that you've added, would be just being being a female is a risk factor that you can't change. We are, by definition, have smaller frame, we have smaller bones, and that puts us at risk for fragility fractures or earlier fractures. There's definitely a lot of literature about transition, perimenopause, menopause, which puts women at risk. So it's very important that both physicians, patients understand at which point women need to be screened and have their bones looked at. Certain medication use, we have unfortunately a lot of patients that have diseases that require medications that directly affect the bone, and it's very important that physicians address this, as well as patients understand that if they're taking specific dosages of medications, for example, steroids, they're fairly commonly used now for allergies, for asthma, for breathing disorders, for skin disorders, for joint disorders. So it's very important to know that if you're taking high doses of medications like steroids, that there'll be a direct effect on the quality of the bone. And it's important to address that issue before it's too late. Certain disorders like rheumatoid arthritis or arthritis in general, especially if it erodes the joints, will also have an effect on the bone and the quality of bone. So these risk factors are important to understand and to address, so we could look at the patient and the bone and prevent it. With osteoporosis, because it's a disease of aging, unfortunately, you can't stop the process. We attempted, and I guess we'll address it as we go on with the medications, but it is a process of aging. It's not something that you could stop or discontinue. The importance is prevention, understanding of at which point can you prevent certain changes, can you slow down the progression, can you improve the quality of life, because it all boils down that if you, God forbid, have a fracture, the fragility fractures, they affect quality of life, and it is important. This is where the detriments of this disease actually are most apparent.
So what would a course of treatment for your patients with osteoporosis look like, and then also osteopenia?
Sure. So I'll take a step back. So I don't believe we defined osteopenia. I know I gave a little, no, that's okay. So osteoporosis is, as we defined it based on the bone density, is T-scores below my 2.5. Osteopenia falls actually in the range of 1 to minus 2.5. So if it's less than minus 2.5, we're in osteoporosis. If it's higher than that, but not in a normal range, it's osteopenia. Interestingly enough, if you look at the literature actually shows that most patients fracture in osteopenic range rather than in osteoporosis. So because by definition, which is a second definition besides bone density, if you have a fragility fracture, then by definition it's osteoporosis. So what is a fragility fracture? Fragility fracture is a fracture of a bone that happens if you fell or did not fall from a standing height. So these would be falls that you tripped or a mild trip and you fall out on the outstretched arm and you get a wrist fracture, for example, or you tripped or came out of the car, which are more common ones, and you get a hip fracture. Sometimes people fracture and then fall, if you sort of ask the details. So these are by definition fragility fractures, and they usually happen in osteopenic range. And reason being is that one is with osteopenia, there are, it's a description by a bone density, but unfortunately, as being a gold standard, bone density is also has its limitations, and the limitations are it doesn't incorporate the risk factors. that a patient may have. For example, so if I take a woman of perimenopausal or menopausal age, somewhere in 55 years old, who has osteopenia on her initial bone density, but someone who suffered, for example, eating disorders in her younger age, somebody who takes steroids on and off because she has significant asthma and the duration or a course of these steroids is more than 3 months at higher dose, or someone who yo-yo diets and avoids or omits certain nutrients in her diet. This particular individual, although her bone density is in osteopenic range, would, in my mind, and of course, based on her risk factors, be at very high risk for fragility fracture. So bringing us back to that question that you asked as what the course would look like. So the typical course would begin with oral bisphosphonates, and bisphosphonates is a class of medications that has been on the market for some time. And the main goal of these medications is to slow down the bone loss. And the recommendations for initial treatment is anywhere from 3 to 5 years, depending on risk factors, or up to 7 years, once again, depending on risk factors. And these are excellent medications. They unfortunately have a bad reputation. And the reason they have a bad reputation is because these are the same medications that are also used for prevention of the disease. And because they're used for prevention, unfortunately, not a lot is understood in terms of when do you stop these drugs? When do you, or if you stop them, for how long? Or what is the long term? So for a very long time, up until fairly recently, patients were taking these medications for prevention for more than 10 to 15 years. And one of the biggest problems that we face with these medications, although they're excellent, is that they cause what's called atypical femoral fractures. So that's the biggest and most common side effect of this class of drugs if taken long-term or not monitored. Otherwise, they do work very well, and their main goal, as I mentioned, is to slow down bone loss. Okay, and so for initial treatment, for someone, as I mentioned, for this young lady who is 55 with with osteopenia, for example, and several risk factors, or osteoporosis and minimal risk factors, her initial course would be up to 5 years. After 5 years, I would usually discontinue and allow the bones to kind of recoup. And I follow these patients for a year or two, if not more, to see how they do. If this is a patient who is at high risk, if it's a patient who fractures on the treatment, and it does happen, there are unfortunately patients who take medications that are not avoidable or have disorders that are requiring treatments that affect bones, or they have other chronic diseases that affect bones, then continuation of therapy is important. In these situations, there are stronger medications. There are injectables, like Prolia, for example, denosumab, which is also in the similar class as oral agents, which is anti-resorptives. They prevent bone loss. Because Prolia is a slightly different mechanism of action, it also has an opportunity to build bone. For my high-risk patients, there are actually other medications that have been utilized, and these are called anabolic agents. So it's a fancy term to say these are the agents or medications that build bone. So building bone becomes very important. because for some patients, if they are at high risk of fractures or they had fractures and more than one, then it's important to capture the building mechanism and strengthen the bone a little bit with a different mechanism. And these agents, they are injectables, and there are two on the market. One is teriparatide, which is Forteo, and the second one is abaloparatide, which is Tymlos. The one negative side effect, although many of my patients don't mind it as much, is that it's an injection every single day. But they do work very well. There is a minimal side effect. The FDA has approved these two drugs for treatment only up to 2 years. So for someone who's at high risk, if we consider these two medications, then they can only do these injections for up to 2 years. And then they're transitioned either to pills or to something like Prolia, denosumab. We've been lucky. About a year or so ago, we had another medication approved by FDA, which actually is a combination. The mechanism of action, the new drug is called Evenity. I will not attempt to pronounce the generic or the, but Evenity is a medication that it's an injectable also. It's given for a year, and it has an ability to both build bone and prevent resorption or bone breakdown. So this is what we have for treatment. So the initial, just to sort of review and recoup, the initial therapy may be with pills up to 5 years if it's someone who is at high risk and requires additional therapy. It could be someone who's transitioned to any of these injectables, and then after completion of these injectables, changed back to either pills or can remain on denosumab, which is Prolia, up to 10 years in addition to that.
So these are all great medications that you just listed. And I've heard many of my patients who do have osteoporosis say that, oh, you know, I'm getting this injectable or that injectable. But one common question that patients always ask me is about supplements. And what supplements, what calcium, what should I take? And what is your take on all the supplements?
So I will tell you, I guess much of it will be a little bit of my opinion and what's documented and what's researched. So it is very important. In my mind, these medications are excellent, but if you don't have sustenance, if you don't have the backbone for these medications to work, and what is the backbone? It's nutrients. If you want to build the bone, you have to have something to build it with. If you want to hold or stop the resorption, then you still want to have the nutrients to be able to protect and build bone. So the supplements, the calcium, the vitamin D are super duper important. Magnesium is important. Adequate vitamin K is important. So I have a background of nutrition, so I would say food comes first, then come supplements. That's why they're supplements, because you're not able to keep up or you don't get enough from the diet. So I usually recommend for patients to assess their daily intake of their nutrients. So calcium, there's a lot of calcium in different types of foods that we eat. We all know dairy. We all know that dairy is a rich source of calcium and vitamin D. But there are a number of patients who are not able to eat dairy. As we age, dairy is also something that we become intolerant to. So the source of calcium has to come from other foods. On the market nowadays, we have almond milk, we have soy milk, which are excellent sources of calcium. A glass of any milk, low fat, skim milk, almond milk will give you roughly 300 milligrams of calcium. You could also get calcium from nuts. You could get calcium from certain fruits and vegetables. Many greens will give you a good source of calcium.
Mm-hmm.
So data, there are a lot of goals of calcium intake per day. If we go to Institute of Medicine, and that's sort of the minimum that we need of calcium per day, as we grow, we need more calcium per day. Once we hit 40s, 50s, and beyond, the recommendation for calcium is about 1,200 to 1,500 milligrams per day.
Mm-hmm.
So if you're someone who gets your calcium from your diet, I don't really think that you need any supplementation.
Mm-hmm.
I would recommend, after you assess your calcium intake per day, to be sort of critical, because not every day you get the 1,200. So if there are days, and this is what I recommend for my patients, if there are days in your week or in your daily routine that you don't meet that daily calcium intake, then I would supplement it. And the supplementation does not need to be necessarily 1,200. You could supplement with a 600 milligram dose.
Mm-hmm.
The best calcium absorption is from calcium citrate. Calcium carbonate is the most common that's prescribed and recommended, and it is available over the counter. It is okay just to understand that calcium carbonate absorption it's best to absorb it if you take it with food. Mm. Calcium is a mineral that needs acidic medium in order to be absorbed. And that acidic medium usually is heightened when we eat. Mm-hmm. And that's to add to one of the risk factors, because we don't realize that we do that, a lot of people take antacids. Antacids, by definition, change the pH of the gut and make it a little bit alkaline. And this is not the best medium for absorption of the calcium. So if you are someone who's taking antacid and you need it, don't stop it. You could talk to your doctor to see if there are better antacids to control your symptoms. But if you need to take the calcium supplementation, it's best to take it with food. So even though you're taking the antacid, the acidity always increased when we eat. So that would be the best time to absorb most of your calcium. For vitamin D, we all, on this side of the world, as I say, as the sun is lower, there are less rays, so majority of people will have vitamin D deficiency. Now, there's always a debate, well, what's normal vitamin D? What's abnormal? How much do you need every day? I have changed my practice several times in how much vitamin D I give and what doses I use. So the idea is, if you are deficient, then you need to fill up that tank to sufficient levels. And if you have osteoporosis, in my mind, I would raise that vitamin D level to 30. If you don't have bone disease, if you have good quality bone and you know it, and you just want to maintain healthy habits, then having vitamin D levels between 20 and 30, I believe is appropriate. During disease, or when you know that you have osteopenia with risk factors or osteoporosis, then it's best to have adequate vitamin D levels. And that could be either taken in with food or supplementation. Then supplementation is necessary. So how do we supplement? A lot of physicians prescribe 50K of vitamin D, which is a high dose, which is a weekly dose of vitamin D. The data on that is mixed. Vitamin D is an important fat-soluble vitamin. And it will be in foods like fish or different types of oils that we have in our diet that we incorporate. And having high vitamin D levels is also not good because it can lead to toxicity. The toxicity of vitamin D is fairly rare. The importance of vitamin D is that it enhances and allows better absorption of calcium from the gut. Hence, you need both calcium and vitamin D in combination and in adequate levels in order to maintain enough resources for good quality bone. For maintenance, I recommend, let's go back, I guess. Institute of Medicine for maintenance recommends very low doses of vitamin D every day. 400 is what's quoted. And probably if you're not dealing with disorders or diseases, for maintenance, 400 is most likely sufficient. But we're not in that sort of realm. This discussion is osteoporosis and osteopenia. So for our purposes, the doses are always different. If you have sufficient vitamin D levels, then you do not need more than 800 to 1,000 every day to maintain that. If you're deficient, then in that situation, you need more. And depending on your absorption, and the reason I bring that up is patients with bariatric surgery. And we do have a large number of this patient population nowadays. Because obesity, unfortunately, is prevalent, and these surgical procedures are excellent and they do wonders. But at the end of the day, depending on the procedure that you've had, you may have issues with absorption. So if you are a patient or an individual who has had this procedure, then these dosages that I'm recommending may not work for you. You may have to speak to your provider, and your dosages may be much, much higher to allow adequate absorption. But for general public, usual recommendation for calcium anywhere from 1,200 to 1,500 per day, food or supplementation, and vitamin D anywhere from 1,000 to 2,000, and I'll give sort of a iffy 5,000 depending on where you start off every single day to maintain adequate levels. The recommendations for other minerals and nutrients like magnesium and for vitamin K are not well defined, but they are important nutrients and minerals to maintain calcium and vitamin D for good bone.
Great. Thank you so much for all that information. I think that thoroughly answers the supplement and nutrition question.
Yes.
So I want to transition now to talking about how physical therapy can help patients with osteoporosis. And I'll start off with reiterating what you said about the bone remodeling cycle, and how bone is actually dynamic, healthy living tissue. I remember when I first went into PT grad school, or actually maybe this was just before PT grad school, and I was doing some advanced anatomy studying, and just fully understanding that there's this cycle, this remodeling cycle going on with the osteoclast and osteoblast cells balancing out and just maintaining that equilibrium and strength and the integrity of the bone itself. So when I work with patients who have osteoporosis or osteopenia, I tell them about Wolff's Law, and how Wolff's Law states that bone is laid down in areas of high stress and reabsorbed in areas of low stress. So what that means for us as physical therapists, and for people who have osteoporosis, osteopenia, or are trying to prevent it, the bone is altered in its shape, strength, and density by these external forces. And now you can apply these external forces by physical activity, by doing bone builder exercises such as weight-bearing activities, resistance training, weight training, and all of these tailored exercise programs that physical therapists can guide you through. Now, that's a huge part of, on my standpoint, and why doctors always say, you need to exercise. But what exercises exactly are good? Some people don't know because there's mixed information out there. But what would you say? Why do you recommend physical therapy for patients with osteoporosis?
So exercise in general is very important. To put everything under umbrella, it's weight bearing exercise.
Mm-hmm.
So weight bearing by definition is your movement against gravity.
Mm-hmm.
So that by doing weight bearing exercises, you're allowing the muscles to move, and that motion of muscle and pull and tug on the bone, as you mentioned, will improve and strengthen the bone. So there are different types of exercises. Literature and data suggests that so weight bearing or posture strengthening or balance strengthening exercises are very important for osteoporosis, and at least 30 minutes a day. Now, general population knows that for healthy habits, 30 minutes a day of cardio or any activity is important. For bones, just as much, but different type of activities. So for weight bearing, I find, and you could, I guess, add to that, that you don't really need to do much weightlifting. It's enough to even pick up a small object against gravity, and it's the motion and the type of the motion, which is why I send patients for physical therapy, that allows the bone to strengthen. Now, with osteoporosis, the crucial part of exercise is to focus on balance and balanced activities, or activities that allow patients to strengthen that, and posture strengthening. Why? Because we want patients to know if they fall, right? The balance will prevent from their falls, and falls is what's crucial because they will lead to fragility fractures. Now, there are a lot of different types of exercises that have been shown to improve bone strength. Pilates is one, yoga is another, and there have been studies showing that these types of exercises are actually important. The trick, though, is not every exercise within these types of activities is good for patients with osteopenia or osteoporosis. So the idea behind seeing a physical therapist and working with someone is that that person will be knowledgeable enough in which exercises would be important not to do. And that's why I rely on the expertise, because one thing, it's important to do the weight-bearing exercises and activities. The other thing is to make sure that you don't hurt yourself, because these simple activities that are meant to strengthen the core, for example, or allow spinal stability, if not done properly, can actually cause problems. It may sound funny, but there's actually the right way to sneeze, if I may, as you get older, because you want to make sure that you don't hurt. If you have fragile bone and you have very weak spine, that you don't hurt yourself and you don't get a fracture. People do fracture when they sneeze, when they have severe disease. So there is the right way to do things as we age, and it's very important to work with someone who can lead you.
So yeah, I'm actually going to be doing a free lecture for everyone who's listening on Friday about safe exercises for osteoporosis, because that's a whole nother discussion, and I could go on and on about it, and I will on Friday at 10:30. So if anyone who's watching is interested in signing up for that Healthy at Home lecture, you can just send us a message or email the contact info that you're seeing here, and we'll get you signed up for that lecture. But one of the things, Dr. Rubinova, that I always tell and explain to my patients, that what's happening when you're doing this resistance training that you're mentioning is the muscles contracting, and the tendon that connects the muscle to the bone is pulling on that bone. That's going to promote that excess stress being applied, and then promote the bone builder cells to increase in activity. Pilates, obviously, you know that I'm also a Pilates practitioner. And not only is Pilates great for mind, body, total body conditioning, but I love it for managing and treating osteoporosis and osteopenia because we use the spring resistance, we use weights, there's tons of weight bearing. And like you said, there are certain exercises that in Pilates need to be modified. And that's why working with a physical therapist who's also a Pilates practitioner who knows about osteoporosis contraindications is important, because there are certain exercises you want to promote. Like the National Osteoporosis Foundation mentions that extensor back training. So learning to move into extension, because what is the one motion that we want to be preventing or avoiding is that repetitive flexion. And the extension, there's tons of Pilates exercises for extension that are wonderful with resistance. And I've seen tremendous benefit in improvement in people's posture. And overall, you just feel better when your posture is improved, your morale. So that says something too. But balance as well. The National Osteoporosis Foundation, I know, recommends that. They have 4 recommendations: daily walking program, balance training, extensor back training, which I loop in core strengthening with, because you need to have a strong core, not just back extensors, to have good posture. And did I say resistance training?
That's
so,
part of it, yes.
Yes. So, and then the resistance training or the weight bearing if I didn't. Well, that was in the walking. So, but I'll be going into that much more in detail on Friday. But I wanted to just finish up our chat with hearing from you if you have any final recommendations.
So the final recommendations would be that it's always great to be proactive. Prevention is the name of the game. Now,
Yes.
we can't avoid the aging process, but we can embrace it. We can be open-minded, and we could understand what each of us needs. We all know our family history. We all know our risk factors. You mentioned National Osteoporosis Foundation. It's an excellent resource for both professionals and patients. It has a wonderful sort of way of explaining things in simple terms. It has calcium calculators and nutrition guidelines for preventing and protecting bones. It has videos and opportunities to look at different types of exercises that you could do at home. It allows you to basically understand the disease process. Now, I have no connections to NOF, so it's not but I find that it's an excellent resource when you need basic information, which you could take back to your providers and to your physicians and build on it. I find that we don't screen patients when we should, for whatever reasons. Most common, as I mentioned earlier, is that it's a silent disease. We have other chronic diseases that we worry about, that osteoporosis always ends up being on the back burner. So you as a patient, I believe, need to be proactive and open-minded, because nowadays we have all this flow of information. I don't believe we screen men at the right time. They are the population that unfortunately is sort of looked at when it's too late, when they already have a fracture. But they could be screened. They should be screened early, especially if they have risk factors. I find that in patients with diabetes, and there is data that supports that bone density sometimes don't capture the true process that happens. So patients with diabetes and medications that cause disease should be screened earlier than the recommendations. And this is something that we as patients can be proactive about. Diet is important, exercise is important, and all of it in a nutshell is step by step leads to prevention, and hopefully prevention of one more fracture. We have too many.
Great. Wonderful. Well, Dr. Rubinova, thank you so much for your time. This was so informative. I really thank you for sharing your knowledge and your expertise. I want to thank everyone who also has been watching and viewing this chat. Know that this recording will be posted on Inspira Physical Therapy and Pilates Facebook and Instagram and our website. And then Dr. Rubinova will have the recording herself and will be sharing it as she sees fit. So thank you again. If anyone is interested in signing up for the free safe exercise lecture that I'll be giving on Friday, just send Inspira a message. You can email us at hello@inspirapt.com or just message us here on social media on Facebook or YouTube. So, Dr. Rubinova, thank you so much.
Thank you, Melanie. I really appreciate it.
Of course. And enjoy the rest of your evening.
Thank you. Be well.
Bye-bye.